I'm gonna first start off with disclosure. Our group receives research funding from industry, from Philips, from Google, from IBM, and from Merck, but the bulk of our funding comes still from the government, from the National Institute of Health. I represent a large global consortium of computer scientists, engineers, clinicians, not just doctors, but nurses and pharmacists, and we're all interested in leveraging data that is routinely collected in the process of care. This is just a very quick overview of some of our partners, and you could see there ACC is one of the new partners of our group, but we are teaming up with hospitals, with universities, with both local government and the country government in terms of creating an ecosystem that could make the most value out of the data that is being collected. Our flagship project has been mentioned. This is MIMIC, Medical Information Mart for Intensive Care. And this is a very high resolution data repository of all data that is obtained for patients being admitted to Beth Israel Deaconess Medical Center, which is the hospital where I work in. And when I say all the data, I literally mean all the data. These are data coming from the bedside monitors, so you're gonna have waveforms there. You're gonna have the notes that are written by the doctors, the nurses, the chaplain, the social worker. You also have the laboratory results, and all the medications and all the interventions are time-stamped. And then every year we buy the death records from the government so we could update information about survival of the patients even after they leave the ICU. For a fraction of them, they come to Beth Israel Deaconess Medical Center for primary care, so you would get some information too in between the hospitalization. And this year we're gonna be releasing the 4th version of MIMIC, so MIMIC 4. In addition to the data that I just mentioned earlier, we will be putting in medical images. So there will be 500,000 chest x-rays that are not just linked with how the radiologist read them, which we know is far from perfect. The images will now be linked to what happened to the patient. It will now be linked to the electronic health record. So I think that will open up a whole new avenue of research. We will be discovering patterns that might be associated with how patients respond to treatment, with how the disease goes into a trajectory, and we're excited about that. Very early on, we realized that a single-center database is useless. When you start submitting papers to editors, they're always going to be skeptical. We're not sure how generalizable are your models. So in 2015, we partnered with Philips, and we became custodian of a much larger ICU database coming from more than 300 hospitals in the United States. And there will be a workshop going over some of the characteristics of this database. And the resolution is similar. You're gonna have vital signs every 5 minutes. You're gonna have medications that are time-stamped. And you will have hospital survival data. And in the true spirit of MIT, we were able to convince our partners at Philips to make a subset of this database also completely open access. I could talk for hours why we think that that is the right approach, that data should be freed from the prisons of servers and allowed to reach as many brilliant minds as possible. We think that that will spur innovation. If our group were the only ones who had access to the database, it would have taken us decades, if not centuries, to be able to cleanse the database and curate it and identify different concepts. As you know, this data was not collected for the purpose of research. It was not collected for the purpose of applying machine learning. So this data that we have is going to be very dirty. There's going to be a lot of missingness. There's going to be a lot of artifacts. And you don't have variables such as acute kidney injury. You're going to have to come up with definitions. You're going to have to implement some of the validated definitions, and you're going to have to come up with rules on how to identify that cohort. So this requires really a very intense collaboration between people with different backgrounds. And that is what we are all about. Creating those links between the computer scientists, the engineers, the data enthusiasts, with the people who know best about this data, the nurses, the doctors, the pharmacists, and other allied health professionals. But creating the database is not enough. You need to have a workforce that is ready to take the most value out of this data. And Our group published a textbook called Secondary Analysis of Electronic Health Records, and it's a cookbook. How do you start off with a research question and then go on to try to extract the elements that you need from this very dirty database? And this textbook is completely free. It was published in 2016, and since publication, it's been downloaded more than 350,000 times. So you could see there that there's a strong interest in being able to improve our understanding of health and disease by interrogating the data that we routinely collect. The best part of our job would be going around the world as ambassadors of health data science. We feel that one of the biggest challenge of moving the field forward is the fact that the clinicians and the data scientists are still living in separate worlds. And breaking down those silos would be crucial for us to really leverage what we have, the tools as well as the data. So we organize these events. Some of them are workshops. So tomorrow, this afternoon and tomorrow, there will be hands-on workshops on machine learning, image recognition, natural language processing, and hopefully that will prepare you to what we're planning next year, which is actual data hackathon, or what we call Datathon, where teams are formed with people coming from different disciplines, and over a span of a weekend, you will try to complete a health data science project. So we have initiatives in South America, in Asia, in Europe, as well as Australasia. And the goal here is to really form regional hubs. What we're trying to do is to connect all our partners within a certain region and allow them to help each other, because they're all interested in the same thing. And the process of creating these databases and creating an ecosystem around these databases is not straightforward. So what we want to do is to leverage each other's lessons learned, so that no one is starting from scratch if they want to pursue this direction. We spoke about this Datathon model to support cross-disciplinary collaboration, and this was published in 2016 in Science. So we were very excited to share and replicate this approach to health data science around the world. Over the last 2 years, we've been inundated with headlines like this, and to be honest, it's getting irritating, because what we're afraid of is that we build so much hype around AI, and then at some point it won't deliver. You won't see the improvement in health outcomes that we promised, and because of that, we feel that there's a potential to really fail big time. But there have been, but before we dive into some of the successes of AI, what I wanted to do is to take a step back and ask ourselves, well, what are really the biggest issues in healthcare that need solving? And every time I talk to data scientists, they said, come on, give me a list that I could work on now so I could change healthcare tomorrow. And luckily, I actually found a list, and this list came from 1989. It was a list that brought about the Agency for Healthcare Research and Quality. It was a list that was put together by the Institute of Medicine, and it was a report that pointed out escalating healthcare costs, wide variations in medical practice patterns, and evidence that some health services are of little or no value. Mind you, this is 1989. Fast forward to 2019, these are still the top 3 problems that we have in healthcare, not just in the United States, but around the world. It seems like we have not made any progress over the last close to half a century already in terms of addressing the biggest problems in healthcare. So healthcare differs from other industry in that as the technology gets better in other industry, the cost would actually go down. So just to give you some nostalgia in here, on the left-hand side is what a 5 megabyte hard drive looked like in 1956. And that could house one song, as you know. So if you want to listen to 10 songs and go running, you're gonna have to carry 10 of those to be able to enjoy your run. In 1981, if you'd like to purchase a 5 megabyte hard drive, it's close to $3,000. Fast forward to 2019, where you could get a 128 gigabyte hard drive on Amazon for less than $20. And just to remind people, 1 gigabyte equals 1,000 megabytes. Great example of as how technology improved, the cost went down. It's the opposite for healthcare. As we incorporate more technology into healthcare, as the technology gets more sensitive, gets more accurate, the cost is spiraling out of control all around the world, wherever we go. And there are so many reasons why that is. And again, we could be talking here for days and days, dissecting the different factors contributing to this, but I'm just gonna highlight a few of them. So there's still a lot of waste in healthcare in the United States. Based on data from 2009, they said that for every dollar that we spend on healthcare, 30 cents has no value. It doesn't add any improvement in inpatient outcomes. It doesn't add any efficiency into the health system. There are so many reasons again why there's waste. Two of them are over-testing and over-treatment. Over-testing leads to over-diagnosis, and mind you, over-diagnosis does not mean a wrong diagnosis. It's the correct diagnosis of a disease that is never going to bother you in your lifetime. An example that is often given for over-diagnosis is thyroid cancer. In the United States, over the last 2 decades, the number of thyroid cancer detected has tripled. In Korea, it is now the #1 most common cancer diagnosis. They've seen a 15-fold increase in detection of thyroid cancer, and that's because we have much more accurate ultrasound that could detect the smallest thyroid nodule. Every time we see a thyroid nodule, we have to have a biopsy, and we see some malignant cells, and we have to perform some surgery. But it's very interesting to note that in the US or Korea, we have not seen any change in not just the death rate, but also the morbidity from thyroid cancer, even though we have improved the diagnosis and treatment of this condition. We think that over-testing is gonna get worse, over-diagnosis is gonna skyrocket. And why is that? It's because we're gonna be using more and more wireless sensors that will be constantly monitoring our physiologic signals. We're discovering more and more omics biomarkers so that there is a potential to find a lot of abnormalities that will probably never harm us. But since we discover them, we're going to be anxious about them. We're going to be seeing someone to see what we can do to try to address those abnormalities. And for that reason, we might potentially make the problem of overtreatment worse. Right now, these are the 4 top procedures, surgeries that are considered as examples of overtreatment. So at the top of the list, it would be knee procedures, knee arthroscopies, knee cleansing. Second in the list would be back procedures. And then, of course, the one that has been in the headlines for the last few years would be placement of cardiac stents. There are very limited scenarios where cardiac stents have really been proven to improve outcomes, but it's being done indiscriminately every time they see any blockage in the artery. And then cesarean sections as well. There are a lot of surgeries that don't require a cesarean section that's being performed. Moving on to care variation, I'm going to quote Arnold Relman, who was a former editor-in-chief of the New England Journal of Medicine. And for clinicians here, this will come as no surprise, but for the public, every time I quote this, they're shocked. Many people think that doctors make the recommendations from a basis of scientific certainty, that the facts are very clear and there's only one way to diagnose or treat an illness. In reality, that's not always the case. I would say that's never the case. Many things are a matter of conjecture, tradition, convenience, and habit. And one of my favorite stories, the people in my group have heard this story so many times. This is Vinod Khosla. He's a venture capitalist. And over the last almost 10 years now, he's been investing a lot of his money into healthcare. And during one of his interviews, he was asked, what did you find most surprising when you went into the field of healthcare? And he said, I was shocked of how bad healthcare delivery is. And he goes on to narrate a research where they had a case vignette of a patient who has heart disease. And they included as much details about the condition of the patient, the type of symptoms, the duration of symptoms, all the tests that have been performed. And they gave this case vignette to 40 seasoned cardiologists across the United States. And there was only one question at the end of the case vignette. Will this patient benefit from open heart surgery? And you think that these are 40 experienced cardiologists across the United States, that there will be a consensus. It was 2020. So 50% of the cardiologists said this patient should be referred to a cardiac surgeon because we feel that an open heart surgery is indicated, and the other half said medical treatment is optimal for this patient. So it's a bit unnerving to think that whether you or your parents would be recommended open heart surgery is totally dependent on which cardiologist you or your parents would see. And that wasn't the end of the research. They actually went back with the same case vignette to the same cardiologist 2 years later. And within the span of 2 years, 40% of the cardiologists changed their minds already. So again, there's so much variation, there's so much biases that take into effect every time we make those complex decisions. And we think that this is an area where AI could really be very useful or very helpful to healthcare providers. It could reduce variability around complex clinical decisions. It has the potential to move clinical decision-making from intuitive to data substantiated, from the realm of art to a domain of science. 2016 marks a landmark year for artificial intelligence. That was the year when we had a publication demonstrating that AI systems beat ophthalmologists in the detection of diabetic retinopathy when given retinal images. That was also the year when we read about computer systems beating dermatologists in terms of being able to detect skin cancer when shown pictures. But I would argue that image classification is a low-hanging fruit when it comes to fixing healthcare. I'm not discounting the value of image recognition. There are areas out there that do not have enough radiologists, that do not have ophthalmologists, that could really benefit in terms of improving the diagnosis of conditions. But I would say that where we need machine learning and AI would be in the day-to-day complex decision-making, such as, does my father need open heart surgery or not? I work in the intensive care unit, and almost all of the decisions that we make are complex, and the guidelines that we get from clinical trials are not very helpful. So in the field of critical care medicine, less than 10% of studies, when you look at different interventions in the ICU, have been shown to have some benefit. 90% of the interventions that we're testing, it comes back as negative. So on average, this particular intervention is not going to be helpful for your patient. But I would argue that I don't have an average patient. So how do I translate the finding of a clinical trial where they enrolled a heterogeneous group of patients? How is that relevant to this 84-year-old gentleman who has an ejection fraction of 30% with an FEV1 of 1? I couldn't say that this patient is an average patient, so that's probably not going to be helpful. So one of the projects that we completed using both databases is the use of reinforcement learning to try to see whether we could come up with better decision support for intensivists who are dealing with a low blood pressure or hypotension all the time. This is the hallmark of critical illness. And the treatment of low blood pressure, you have three options. You could ignore it, you could give fluids through their veins, or you could use vasopressor medications to increase the pump function of the heart, as well as vasoconstrict your blood vessels. And we have very general guidelines on how to treat hypotension in the ICU. We have a target number of 65 that's actually based on one single center study with 111 patients. And there's also some recommendation of a volume of fluid of 30 mils per kilo, which if you look at the back of the guidelines would say that there's actually no study behind this recommendation. So we feel that this is ripe for improvement with the help of machine learning, looking at the billions of data points that we have obtained in the intensive care unit. So we use the methodology of reinforcement learning. That is the methodology behind the AlphaGo, which is the AI system that beat a human expert in Go. But it's not straightforward. This AlphaGo is very different from the patients in the intensive care unit. In AlphaGo, you could really test different options of different moves and see what happens in the end. Did they win or did they lose? In the intensive care unit, the data is not going to give you all possible interventions or options for the doctor. So I think this is a method that is useful if you just want to optimize a limited range of options in terms of addressing a specific issue that you're dealing with. And I'm just going to end with this collection of studies that we have completed, I think, in the last year or so. The first one does not even involve any fancy machine learning. And this is looking at whether we could improve the way we interpret laboratory results in the intensive care unit. So for the clinicians out there, you probably know that the way we interpret results is that we're given a reference range. And the way the reference range is established is that in the United States, every couple of years, they would identify 200 healthy individuals. And whatever is the central 95% of their laboratory test, it becomes the reference range. And for us in the intensive care unit, that does not mean anything. So maybe there's a better option. And for this particular study, what we did was to just compare the central 95% of laboratory results in the ICU of the patients with the best outcome versus the patients with the worst outcome. And it turned out that there is still so much overlap between the two populations, even outside the reference range. And we could do this by plugging in different outcomes that we are interested in. So for this particular project, we looked at serum lactate, and we found that the truly abnormal serum lactate should be above 4 and not above 2 as recommended by the reference range. We could also do this with electrolytes. So I would say 10% of our time in the intensive care unit is checking electrolytes and correcting electrolytes. And again, that recommendation is based on a study looking at patients with heart disease. And maybe the threshold of 4, which is what we use now, does not apply to everyone in the intensive care unit or does not apply to everyone on the floor. So what we did in another project is to look at what's the risk of an arrhythmia with different values of serum potassium, and can we individualize that risk so that we don't have to correct a serum potassium if it doesn't need to be corrected in a particular situation. So I'm going to end off with these 2 questions, and this is looking at some potential benefits of looking the data here in New Zealand. So hypertension, as you know, was defined, the definition was changed recently in the United States. The cutoff was lowered from 140/90 down to 120/80. And a lot of practices around the world followed suit, even though the research was based primarily on Americans. So my question here is, what should be the blood pressure cutoff for hypertension in New Zealand? You have tons and tons of blood pressure readings, and you know what happened to those patients who developed stroke, who got admitted for a heart attack, and who died. And in the same token, what should be the blood sugar target for diabetics in New Zealand? You cannot apply the Accord trial and just assume that the findings of Accord trial would also be true for the Kiwis. So these are some of the very low-hanging fruits that you could do by leveraging the data that you already have. And with that, I'm just going to end my presentation. Thank you.